Hi everyone, I'm Sue. I'm one of the interns this year. I'm finishing up intern year. Welcome. Thank you so much for listening to this video. This is essentially to provide you resources that you're going to use, that you're going to want to use on particularly CRMC awards, but you can translate this across all inpatient rotations. And then most importantly, and our biggest focus of today's presentation is to walk you through what a typical day of CRMC looks like from start to finish. I teamed up with Omar, our chief resident, to really provide you guys with this information and to facilitate the beginning of your year and to give you guys a resource that you can continue to look back on as needed. The first thing that I kind of want to go over is just this H&P template that Omar shared with me. And the reason why this is particularly important is because, and useful, is because it condenses all the information into one particular sheet, right? And then the other thing that I really like about it is it follows the SOAP format, right? So we have the past medical history, medications, family history, then we have our objective data all right here, and then you can flip it over and it'll be blank, and then you can write your assessment and plan. So we can go through just some of these parts on here. I know you guys have done a lot of H&Ps, but for past medical history, that's just your one-liner, and we're gonna go on and on about this, and we have a different resource, a specific one-liner resource that I'll be going over. But essentially to kind of draft my one-liner and my past medical history, it's really looking at the discharge summary and filling it, looking at the problem list to fill in any problems that the discharge summary was missing. And then the medications, it is so important to look at the active medications on and print their medications and bring it down to you when you go to take your H&P, because many patients will not know what medications they're taking unless you physically say the name and ask them about it. And so I always just, it's so easy just to copy and paste their active medications into either a word sheet or a notepad, and you print it and you bring it with you and you just check yes, taking, no, not taking, right? And so then you've just done your med recon. And then this is a little bit trickier when someone's maybe altered or coming from a skilled nursing facility, or maybe their medications are not up to date. Then you will have to call the skilled nursing facility or family members to really verify this information. So in terms of the chief complaint, I write down, personally for me, I write down exactly what the patient tells me is the reason they came to the hospital. And this is for you to fill in, and this should tell the story of what brought the patient, the story of what led to this patient's hospital admission. And it should show your thought process, right? It should show what you're thinking about, what questions you asked, what narrowed you to one diagnosis. All of that should be right here. And then this little box is very, very nice, because these, you'll come to see that these are the 5 very, very important things, especially when someone's being admitted to the hospital. Not only can you not admit a patient without filling these out, maybe not bowel and pain, but definitely diet, code status, but your senior resident is going to want to know this information, and your attending is going to expect you to know this information. So code, you need to ask everyone being admitted about code status. You should not leave that room unless you have a code status. You physically cannot admit someone if you don't have a code status with the admission orders. I know it gets a little uncomfortable at first, but the more times you do it, the better. And so for me, I always start off with, given that you're being admitted to the hospital, I do have to just make sure that we know what to do in case your heart were to stop. And so in the off chance, I don't expect that this is going to happen, but in the off chance that your heart were to stop, would you want us to resuscitate you? Meaning provide chest compressions, give you medications to bring up your blood pressure and to keep your heart beating, and to potentially give you shocks if we're able to. And I usually pause right there, let them answer the first half of the question. And then if they say yes, or no. Doesn't matter. I let them answer that part. And then I follow that up with, typically when your heart does stop, we need to you're not getting enough oxygen and you don't have the awareness to be able to breathe on your own. So either during the code as we're resuscitating you or afterwards, you'll likely require a breathing tube that we put down your throat. We hook you up to the breathing machine and that takes over your respiratory function. Would you be okay with us doing that? And really, please don't leave any patient's room without knowing their code status. This is very important. Diet, there's certain considerations that you need to take into account. Are they a diabetic? Do they have end-stage renal disease and need a renal diet for low potassium? Are they in heart failure and need or have a history of heart failure and they need a cardiac low sodium diet? So those are the three major ones I would say is just renal, diabetic, and then cardiac. And there's other things that we can do too, but those are typically the ones that you'll see time and time again and just give special consideration to. The other kind of thing that I'll talk about really briefly here is sometimes you'll have like older patients and they don't have their dentures, and you can only imagine how hard it is to eat a diet. So we have puree or soft food. Usually soft minced food is good for them. And then the other thing is if someone comes in altered and you're waiting for a speech eval, a formal swallow study to make sure that they're able to swallow, just make sure you do not start a diet. DVT prophylaxis, we'll kind of talk about in the PowerPoint presentation, and there's really only 2-3 options that we'll go over. Pain, I usually stick to the same thing, and I always have a PRN or else you're going to get continuously paged. I just do Tylenol 500 milligrams every 6 hours PRN. And then just always caution with patients that have liver disease. And then bowel regimen, always Doxena, BID, Miralax daily. Otherwise, we can continue to go through this. Really important to get a sense of what they do. What is their functional capacity at baseline, right? Are they able to walk on their own? Are they able to perform the ADLs on their own? Any focal neurodeficits, like these are very, very, very important to know because this kind of dictates like what their baseline is, and you'll be able to monitor how different from their baseline is this, right? And when you talk to patients about this, you always want to compare it. Some patients will come in with weakness, and so you want to just clarify, what were you able to do in the past? And then how has that changed? What are you able to do now? And then you can fill in the vitals from the ED, write down so now we're getting into the objective data. Write down your physical exam, write down the labs from the ED and the micro, and then the rest of the imaging. And we pay particular attention to echoes, TEEs, and that's just because we always want to be aware of someone's heart function, especially before we give fluids. So this, I highly recommend you guys, if you guys want this, I can talk to Omar about sending it out and just printing it and having it ready on call day, printing a lot of copies and just getting in the habit of like collecting all this information. And this just makes it so nice to have in one sheet.